Hello all, it's Farouk here. Welcome to another episode of Orthodontics in Summary. Today we're looking at Dr. Flavia Artese's lecture entitled Expanding the Lower Arch, Is It Really a Forbidden Frontier? Now Dr. Flavia started off by describing that hallmark principle in orthodontics of maintaining the lower incisor position as established by Tweed in 1944. She went on to describe 4 clinical indications where we can change the lower incisor inclination. That when the patient has a good profile and there's an arch length discrepancy or mild crowding. The second of levelling the lower arch if there's a curve of Spee. The third of class 2 compensation, and the third of class 3 decompensation prior to surgical correction. She went on to speak about the literature, and there are a series of systematic reviews looking at low incisor inclination changes, the most recent by Tepedino in 2018. However, they all do look at retrospective studies. The key information to glean from the literature is that recession can occur, and there are 3 factors at play. That of visible plaque, the second of the amount of proclination, and the third is the gingival biotype. She went on to describe visible plaque as being the key factor. It results in inflammation occurring, which results in loss of connective tissue. The second of proclination. Now there is a difference within the literature and also clinical experiences. Some indicate large changes can take place in the proclination without any effects, and they indicate very narrow margins. So it's unclear regards to proclination. And she moved on to biotype, which was the mainstay of her lecture. She described periodontists calling biotype the periodontal biotype or the phenotype, called phenotype because it's something which can be changed. Now there's been changes within the classifications, but there are 3 types of biotypes. That of the thick, flat biotype, the patients we have the least concerns over. That of the thick, scalloped biotype, being the second or intermediary, and the third, the one we have the most concern, being the thin, scalloped. And she described how these appear from a diagnostic perspective. Now, the thick, flat patients have a thick fibrotic gingiva. They have a broad zone of keratinized tissue. So that's the vertical keratinized tissue from the gingival margin down to the mucogingival junction. And interestingly, 2 shapes also featured in this category. Patients who have square-shaped teeth tend to be thick, flat in their gingival biotype. Moving on to the thick, scalloped biotype. So for these patients, they also have a fibrotic gingiva, a thick gingiva. But here they have a narrow zone of keratinized tissue. The vertical height of keratinized tissue from the gingival margin to the mucogingival junction is narrow. And the teeth are slender, again teeth featuring as part of the diagnosis. The third, and the one we have the most concerns over, so these guys have a thin, delicate gingiva, the same narrow keratinized zone of attached gingiva, and interestingly they have triangular shaped teeth. Now, how do we assess these? Well, we may perceive our visual assessment of these categories being sufficient, but the literature states that we're wrong. And by Egbali in 2009 showed that we only diagnosed correctly 50% of patients who fell into the thin scalloped biotype, the ones we have the most concern over. Now, the good news is in the population, the majority of people have a thick scalloped biotype at 51%. But there are 40% of patients that are thin scalloped that we need to watch out for. So how do we diagnose it? Well, she gave 2 key methods, one of the clinical diagnosis and the second using adjunctive scans. The diagnosis clinically involves visual assessment, yes, but also using a periodontal probe, something relatively simple. And we can discern between a thick fibrotic gingiva and a thin fragile gingiva by simply looking at translucency with a periodontal probe through the free gingiva, knowing that the thin gingiva or the fragile gingiva is 1 millimeter thinner. So if we see a translucency, it is in that category. Second, looking at tooth shape and also assessing the amount of keratinized tissue that's present. Now moving on to using scans, she spoke about using cone beam CTs. She did say from the outset cone beam CTs aren't infallible and bone less than 0.6 millimeters will not get picked up in cone beam CTs. Now when they have had these scans carried out on patients with low incisor inclination changes, it's been quite interesting the results. From a bony perspective, there's very little bony changes anteriorly. A majority of the bone loss, if it takes place, occurs in the canine and premolar region within the lower arch. She has exercised caution in changing the lower incisor inclination position. And if it is to take place, one should consider changing the phenotype, having a graft take place from a periodontal perspective. Now here she left the questions still yet to be answered as to when does the graft take place, which type of graft is preferred. She spoke about how there's a consensus paper within the Academy of Periodontology in America which says there's not enough evidence to state orthodontic movement is implicated in the loss of periodontal tissues. That's it for another episode of Orthodontics in Summary. Please do subscribe and look forward to the next episode.